is shown in the same way. Visual receptors in retina, first order neurons, bipolar cells in a nuclear layer, second order neurons, ganglionic cells in ganglion cell layer, then optic nerve, optic chiasma, optic tract, then third order neurons, lateral geniculate body, optic radiations, visual cortex. I want to say one thing, that in my first part where I have said the first order neurons and the photoreceptor cells, I said it because looking from prep ladder, the teachers, they were talking that photoreceptor cells are the first order neurons, so I mentioned that. But in books it is written that the first order neurons are the bipolar cells in the inner nuclear layer. So I will suggest you to follow the book only. So let's follow the book, and we will do as what book says. So first order neurons, they will be bipolar cells, second order neurons, that will be ganglionic cells, and third order neurons will be lateral geniculate body. So this is the pathway. So here now we will be talking about the lesions of visual pathway. So here you can see it's again the same diagram. It is shown in much beautiful way. So here what we can see is that total blindness of the ipsilateral side. So when the nerve fibers are, there is a lesion at this layer of nerve fibers, and both the nerve fibers, nasal and temporal fibers, there is a lesion. Then what happens is, we know that these are arising from the same eye, that is the right eye. This is from the temporal visual field, and these fibers are from the nasal visual field. And if there is a lesion, obviously the impulses will not pass through this nerve. That means that there will be no vision from this eye, so there will be total blindness. Okay, because both the nerves are damaged. So how there is no chance of passing of the visual impulses, and it will not reach to the higher cortex so that a vision can form. So what will happen is, there will be total blindness. Very easy, nothing big. This in part B, it is shown that there is a lesion at the optic chiasma. See, optic chiasma. So what we have seen, that optic chiasma means crossing of the nasal fibers of the both the sides. So what will happen is that nasal side fibers will get has the lesion. Nasal side means, where do this nasal fiber impulse from? They get impulse from the temporal side. Okay, temporal visual field. So what will happen is, the temporal side, there will be loss of vision. So from both the temporal side, because nasal side means nasal fibers that get the impulses from the temporal visual nasal field, right? So what happens is, that the vision loss of temporal side, which we call bitemporal hemianopia. Okay, bitemporal hemianopia. So now what we will see is that once we have studied this thing, where I have seen what happens when there is lesion at here, okay, and the lesion at the optic chiasma. But there's one more thing that we have to discuss, that is that for the level of first and second year, that is enough. Okay, you just need to know what happens when there is lesion at the optic nerve, then chiasma, then tract, and everything. But once you this third year, and once you are studying in ophthalmology, then what you have to know is what happens when there is lesion at distal part of the optic nerve, and lesions at the proximal part of the optic nerve. So lesion at the distal part of the optic nerve will give complete loss of vision of the affected side, which is similar to this. So there is lesion, with the lesion is at the ear. Okay, this is the left eye. So both the nasal and the temporal nerve fibers, they have the lesion. That's why there is complete loss of vision of the left eye, and there's nothing is affected of the right eye. Now what happens is that lesion at the proximal part of the optic nerve. So when we talk about what happens when there is a lesion at the proximal part of the optic nerve, then what we have to know, that is, this is the optic chiasma. Okay, this whole part is the optic chiasma. So now the lesion at the proximal part, okay, proximal part means this part, okay, of the optic nerve. So what happens here is, the nasal fibers from the opposite side, when it is crossing, little bit of them, they just arch in the another side. They just get arched or curled up in another side, because of which some of the fibers of the nasal part also, they get damaged when there is lesion at the proximal part of the optic nerve. Are you getting me? So what happens is, usually we think that what happens, we think these fibers go like this, right? But they don't go like this. They go in a bit different way. what they do is go and they arch like this, what you can see here, right? So because of this arching, whenever there is lesion at this part, that is the proximal part of the optic nerve, and as I said, this is whole the optic chiasma. So why I'm saying this is whole optic chiasma, because in optic chiasma also similar thing is happening when there is lesion at the anterior part of the optic chiasma. Right now we are talking about the proximal part of the optic nerve, which consists of optic nerve and the chiasma both. So you can see that this is the nasal fiber of the right eye. Okay, here is the temporal fiber and the nasal fiber of the both the eye, that is right, left eye, temporal and nasal fiber of left eye, and the nasal fiber of the right eye. So when there is lesion, what happens here is that you can see both the fibers, that is temporal and nasal fibers, they are getting caught, but along with it, because of this folding over here, the nasal fiber of the right eye, this upper part also gets cut, or is also gets lesion there. Okay, so there is also going to happen a defect. So what kind of defect we see in such situation is, it is shown here, that is the fibers, this is the nasal fiber of the right eye. So nasal fiber means temporal nasal field defect, so there will be temporal hemianopia in the right eye. Very easy, nasal fiber, so temporal hemianopia. But in the left eye, both the fibers they have been cut down, but what happens there is the macular fibers centrally located at the most sensitive to pressure ischemia, thus are first to damage. So the initial visual field defect in optic nerve lesion, this is the optic nerve lesion at the proximal part, is the central scotoma, which progressively involves the whole optic nerve and causes complete blindness. So initially you will see there will be a central scotoma, loss of vision at the central part. After that it will move and it will accompany the whole optic nerve, and there it will result again like the number 8, that is complete blindness. So lesions at the proximal part of optic nerve is causes ipsilateral blindness plus contralateral hemianopia. What happens then is lesion at the chiasma by temporal visual field loss. I have already explained, if there is lesion here, that means both the nasal fibers are crossing here, that means the lesion at the nasal fiber crossing defect means temporal visual field loss. So by temporal hemianopia, very easy, nothing difficult. But the things now comes at lateral chiasmal lesion. Lateral chiasmal lesion means there is lesion at here, this part of the chiasma, lateral part of the chiasma. What is the fiber that is there in the lateral part of the chiasma? This is the temporal fiber, right? So there is the temporal fiber in the lateral part of the chiasma. So how this lesion occurs, that is more important. So whenever there is a lesion of the lateral part, usually it is bilateral, that is both the sides get affected, but sometimes it can be unilateral, that is only one side might get affected, and in this one side only this part will get affected, temporal fibers. If this is the temporal fibers and these are the nasal fibers, then what happens is that the nasal fibers, these will not get affected, but the temporal fibers will only get affected in the lateral chiasmal lesion. This is whole chiasma, and in the lateral chiasmal even on the temporal parts will get affected, nasal fibers will not get affected. Temporal part, there are temporal fibers, right? So whenever there will be lesion at the temporal fibers, what we will see is that there will be problem in the nasal visual field, right? So what we can see here is this binasal, okay, binasal temporal, binasal hemianopia. If there will be lesion at the central part of the chiasma, then both the nasal fibers will get affected, which will result in, since both the nasal fibers are getting affected, it will result in bitemporal hemianopia. When there is a lateral lesion of the optic chiasma, the nerve fibers in the lateral part are the temporal fibers. Since the temporal fibers will get affected, so the nasal visual field defect we will see, that is by nasal hemianopia. Very simple to understand. Lateral chiasmal lesion by nasal hemianopia, and anterior chiasmal syndrome is similar, not exactly but almost similar with the lesion at the proximal part of the optic nerve. Here it has the thing that happens here is junctional scotoma, which is the combination of central scotoma in one eye and temporal hematoma in the another eye. That is the combination of central scotoma in one eye and the temporal hemianopia of the other eye. So Anterior chiasma also means this, and proximal part of the optic nerve also implies the same thing that I have already explained earlier. So both of them, they give the same kind of result. So let's look at what are the causes of the bitemporal hemianopia, optic nerve lesions, and causes of binasal hemianopia. So let's start with optic nerve lesions. So usually the optic nerve lesions will be optic atrophy, very easy, optic neuropathy, acute optic neuritis, traumatic avulsion of the optic nerve. Just, it's not like very important, it will not be asked, but you have to remember the causes, few of them. And causes of bitemporal hemianopia, there is bi, 3 PC and AC. So bi means bitemporal hemianopia, 3 stands for 3D ventricle glioma. This is from Soch, I think I have got this mnemonic from there. P is equals to pituitary macroadenoma, C is equals to craniopharyngioma, A is equals to anterior cerebral artery aneurysm, and C is equals to cavernous sinus aneurysm. Remember just 2-3 examples, and there is a mnemonic. With the help of mnemonic by 3 PC and AC, you can remember this. After that, causes of binasal hemianopia is distension of third ventricle, crossing pressure on each side. So as I said, each side, pressure on each side, and there is atheroma of the carotid or posterior communicating artery. So from this side, no, there is internal carotid artery, it is passing like this from both of this side, like in this way. So whenever there is the atheroma, it will affect which? The lateral side first. So in this way, the lateral side will get affected with the atheroma of the internal carotid arteries. That's it. So this is all about lesions up to the chiasma. This is all about the lesions up to the chiasma. Now the lesions below the chiasma, we will study about that. So till now we talked about till the optic chiasma what kind of lesions are produced. Now from here we will talk after the optic chiasma, that is retro-chiasmal lesion. So if there is lesion at the optic tract or the lateral geniculate body or at the full of optic radiation, means throughout the optic radiations, then we will get the similar kind of result. Okay, what the result we will get is incongruous homonymous hemianopia, incongruous homonymous hemianopia, and congruous homonymous hemianopia. So what does it mean? I will explain you here. So optic tract consists of fibers, one from the temporal side of the same eye and another is the nasal side of the another eye. Okay, so that means that there will be the vision loss in the nasal side of the same eye because there is a temporal fibers there that is getting injured, whereas from the other eye that is nasal fiber that is getting injured. If nasal fiber gets injured, that means temporal visual field gets affected, so temporal visual field will be seen. This is what we will see when this lesion at the optic tract, lateral geniculate body, and as a whole of the optic radiation. Okay, here you can see whole of the optic radiation is same 9 number, it's the whole of the optic radiation. In optic radiation there are two major, divided into two loops or two fibers. Okay, so but right now we will consider as both the loops are getting injured, both the fibers are getting injured. Okay, and we will see that there is the natural visual field defect of the same eye and temporal visual field defect of the opposite eye. Everything is similar. Lesion of the optic tract, lesion at the geniculate body, and lesion at the full optic radiation, you get the homonymous hemianopia. Okay, homonymous means what? Homonymous means that is they are in the same side. Okay, suppose you can see both of them, they are in the right side. Okay, this both the lesions are in the right side. Okay, here also both the lesions are in the right side. So despite there is difference in the visual field, that is this is nasal visual field and this is temporal visual field, but since they are in the same, homonymous and heteronymous are only concerned with which side. Just remember, if the sides are similar, that is right and right, then it is homo. If the sides are different, it is hetero. Okay, side of the visual field defect, not the temporal and nasal, it is different. But when it is comes our left and right, temporal and nasal side, they are different. Okay, it is in the temporal side, it is also in the temporal side, both of them are similar, right? So they are congruous, but the side is different. this is in the left side and if in the right side. So homonymous and heteronymous are concerned with right and left side, and congruosity is concerned with the nasal field or the visual field defect. So when we decide congruous and incongruous looking at the visual field defect, we decide heterogeneous and homogeneous looking at the side, whether it's right side or this left side. If they are similar side, then homo. If they are in different sides, then it's hetero. So in optic radiation, why we have written as congruous homonymous hemianopia is that in optic, usually after the optic chiasma, the radiations they spread out very much. Okay, till here they are coming in a bundles, they are coming together. But after optic chiasma, what happens is that the radiations they spread out. Because these radiations are spreading out, it is not necessary that whenever there is a lesion in the both the side, okay, when there is a lesion at both the side, similar kind of visual field loss will be there because the fibers they are spreading out, right? So let me show you by drawing only. So here, for example, this fibers that is spreading out like this. Okay, so there is a lesion. Maybe lesion might affect these fibers, the lesion might affect this amount of fibers only. So there is a difference in the fibers which are getting affected. So it is not necessary that there will be similar kind of visual loss or visual field defect in both the eyes. That is the reason why it is called as incongruous in lateral geniculate body and in the optic tract. But when it comes in the optic radiations, we can see that in optic radiations there are loops. They lie again together, they all then again come together as a bundle like this, the similar way. So whenever this lesion, the thing is that all of them, there is a chances of producing a similar kind of visual field defect in both the eyes. But up to here, the lesions, the radiations, they are like spread out like this, they're not together. So whenever there will be injury, it's not necessary that similar kind of visual field defect will be produced, because not similar the optic knobs they are getting damaged. So because of these reasons, why the injury from in the optic tract and lateral geniculate body, we call it incongruous, because similar visual field defect will not be produced in both eyes due to spreading out of the radiations and optic knob. But after it comes in the Bauman, these radiations, after they come as radiations, they're arranged in groups again in bundles, and similar kind of visual defect we can be found in both the eyes when there will be the lesion. So it is known as congruous. From at the optic chiasma and in the optic this knob also, similar kind of visual field defect can be produced in both the eyes. So these are also called congruous. Okay, but in this, these are not similar kind of defect are produced, so they're incongruous and homonymous because same side, both of them to produce the, all three of them to produce the lesion at the right side of the eye. So these are known as the homonymous hemianopia. Hemianopia means only one half, so that is called hemianopia. So this is how we can understand. Now this is about the up to the full optic radiation. Let's look at this right now. So this is optic tract, this is lateral geniculate body, and optic radiation, full of the optic radiation. There are three things that we have to can be asked. What is, what are the changes in pupil, what happens in optic atrophy, and what is the congruity. So in pupil, we can say abnormal pupil, that is Wernicke's pupil, and in the lateral geniculate body, the pupil is normal, and in optic radiation also pupil is normal. Whereas optic atrophy, bilateral optic atrophy can be seen in optic tract lesion and the lateral geniculate body, whereas optic radiation there is no any optic atrophy. Okay, and congruity, incongruous, and I've already explained it is congruous, so I don't think I have to explain further.